Good afternoon. Thank you for joining us today. It's my pleasure to be here with you to share with you my thoughts on family-centered care and engagement. My name is Lisa Chiarello, and I'm the Associate Director of Drexel University's College of Nursing and Health Professions Center for Family Intervention Science. This talk is part of our speaker series that we started this year. The talks are recorded and available through our website. So the mission of our center is to study and disseminate family-centered care models that promote strengths, resources, and community engagement, particularly for vulnerable and marginalized families. We aim to improve the well-being of children and adults with medical, developmental, or behavioral health conditions through interprofessional research, education, and practice. I became a pediatric physical therapist because of my love for children, but I found that the most beneficial aspect of therapy has been my involvement with the entire family. My passion for family-centered care and interest in understanding the processes of therapy and mentoring therapists in supporting children and families has defined my research, teaching, and practice. During this journey, I have focused on the therapist's role in optimizing parent-child interactions, children's playfulness, adaptive behavior, self-determination, and participation in home and community life, and family ecology and families' capacity to nurture and care for their children. The construct of engagement unites my family-centered service delivery philosophy and my outcomes of interest. I believe that client engagement, and therefore how therapists foster engagement, is a key mediator to realize meaningful outcomes for children and their families. I would like to begin with a quote from a parent. "This is our child. This is your patient. This is our life. This is your work. This is the creation of our love. This is a problem for you to solve. This is our only Paul. This is one of your many patients." This quote has touched me and has been an inspiration to me as I advocate for family-centered care. Today I want to share the foundation and advances of our understanding of family-centered care and pediatric rehabilitation for children with special health care needs and their families. I'm going to explore how engagement of children and families is a mechanism for adoption and implementation of family-centered care. And I encourage you to reflect on family-centered care as a fundamental approach across the lifespan for all disciplines and practice settings in service delivery, as well as in education and research. To set the foundation for the talk, I would like to share with you 3 descriptions of family-centered care. Family-centered service recognizes that each family is unique, that the family is the constant in the child's life, and that they are the experts on the child's abilities and needs. The family works with service providers to make informed decisions about the services and supports the child and family receive. In family-centered service, the strengths and needs of all family members are considered. The principles of patient and family-centered care put out by the American Academy of Pediatrics are really useful principles. Listening to and respecting each child and family, honoring diversity, and including family preference in service delivery, having flexible organizational systems to offer family choices and provide services that are responsive to family needs, beliefs, and cultural values, sharing complete and honest information in useful ways so family can participate in decision-making and care, ensuring formal and informal supports to the child and family, promoting family professional collaboration at all levels of healthcare, and appreciating and fostering strengths and building family capacity. This was originally published in 1995, which also brings a point. A lot of the information I'm presenting, or some of the things I'm going to share with you, are from the 1990s. Family-centered care and pediatric rehabilitation has been around for a long while, but we continue to need to research this construct and also help translate it into practice because of the struggles in actually implementing family-centered care in real-world practices. The original wording of one of the tenets always just touched my heart, and the wording is no longer in the revised 2012 version, but I'll just share it with you. Appreciating families as families and children as children. Last, I share the definition from the Institute of Patient and Family-Centered Care for its broad application across the lifespan. So patient and family-centered care is an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnership among healthcare providers, patients, and families. It defines the relationship in healthcare by placing an emphasis on collaborating with people of all ages, at all levels of care, and in all healthcare settings. In patient and family-centered care, patients and families define their family and determine how they will participate in care and decision-making. A key goal is to promote the health and well-being of individuals and families and to maintain their control. In a synthesis of the numerous definitions of family-centered care in the field of childhood disability, the following key elements emerged: appreciation of families' impact on the child's well-being, respect for children and family, and responsiveness to family priorities. The status of being a parent and caregiver should be high. We must learn from each other. Family members have valuable information to share about their child. They know their child most intimately than anyone else. And their information should be valued, and it is considered accurate and valid information. This last element, family-professional partnership, was in every single definition that I reviewed. So that is the grounding foundation for family-centered care. It's a shared responsibility for a common goal. Although the family and child may be acknowledged as the key members of the team, often team dynamics, it does not play out that way. Often team meetings occur when family and child are not present. So this is a clear example of how we need to make an effort to make sure that our behaviors reflect our beliefs. The parent must be respected as the primary decision maker. It is our role to provide the family with appropriate and individualized options and thorough explanations, ensure their understanding, and that they have the information to make informed decisions that meet their family's needs. Family professional partnership, again, that grounding element in all definitions, is defined as parents and other family members working together with professionals in pursuit of a common goal, where the relationship between the family and the professional is based on shared decision-making and responsibility and mutual trust and respect. This definition has elements of a combination of relationship plus mutual participation. I'm going to come back later to that in my talk because that's very important. There have been many approaches to providing services to children with special needs over the years. Services have been focused on the child. They've been focused on training parents, which we no longer use that word, and it's not a real appropriate word. And they have been focused on promoting positive relationships between the parents and child. I see family-centered care as a way to take the positive aspects of these various approaches and provide services with, when individualized, include aspects of both the child and parent-centered models, as well as involvement of the community, as therapists try to meet the needs of the family and promote the child's development and function. Family-centered care is supported by many theoretical frameworks, including the systems theory, the transactional model of development, and the ecological model of human development. When we teach the ecological model of human development to our students, we emphasize the role the therapists have in understanding, supporting, and advocating for the community, which requires therapists to make a commitment to learn about and make a connection with the community members and community programs in the neighborhoods in which they provide service. Frameworks that specifically guide physical rehabilitation and health, such as our current model of motor control and the International Classification of Functioning, Disability, and Health, have been influential for our field, emphasizing the role of the environment in influencing outcomes, and thus the need to consider and support the family as part of our service delivery. In the field of early intervention, which is services for young children birth to 3 years of age with developmental delays or disabilities and their families, it has been recognized for over 20 years that family patterns have the greatest impact on child outcomes. These patterns are parent-child relationship, family-arranged experiences, and the health and safety provided by families. More recently, the role of parent self-efficacy has been elucidated. We need to continue to discover how we can best support and strengthen these family patterns and self-efficacy in order to promote optimal child outcomes. A recent review article on family-centered care has summarized the complex relationship between family-centered care and child outcomes. This relationship is mediated by child, family, service, and cultural context. Carl Dunst, a researcher in the field of early intervention, has characterized family-centered practices into two categories: relational practices, such as active listening and empathy, that foster the parent-professional relationship, and participatory practices that foster family involvement and choice, such as supporting families and adapting our approach to their context. In their systematic review of 15 studies of rehabilitation services for children with physical disabilities, Al-Masri and colleagues found that services are family-centered, a moderate to a fairly great extent, as examined by the measures of processes of care. This measure include aspects of providing general information, specific information about the child, coordinated and comprehensive care, respectful and supportive care, and enabling and partnership. They cautioned, however, that this measure has fewer items for participatory practices, so we may not really know the extent that our services foster family involvement. Family-centered care has been shown to have a range of positive effects on the child and family, but research is limited across various populations and settings, and it has been noted that we do not have adequate guidance for implementation. As we continue to advance the field, both through research and implementation to practice, it is essential for us to have a clear direction. First, the outcomes of interest that best meet family and child needs, and two, the specific practices needed to realize these outcomes. Also, we need to be cautious that family-centered care does not mean inappropriate expectations of family participation without support, as that may actually cause further stress to the family. Not all families can participate to the same degree, and partnership does not mean equal responsibility. The responsibility can be different, but shared, and it can change over time. As an example, Leiter found that in relationship to the expectation of parents to implement therapeutic recommendations, mothers indicated they did not have adequate knowledge, they believed that the therapist's input was of more value, and they didn't always feel that they wanted to or were able to take on this role. An important question has been raised. Has the focus been on educating parents to have more responsibility versus developing a true collaborative relationship? Although parents believe that services on average are family-centered, they do want more guidance from healthcare providers in making decisions and implementing and coordinating a care plan. So I do believe that we need to advocate for family empowerment and engagement, but with a dynamic balance of providing them the support. So we have a general sense of what family-centered care is, and we know that family-centered care has positive effects on children and family, but how do we really provide family-centered care? 20 years ago, a small qualitative study was done entitled Family-Centered Services, service providers' discourse and behavior. The study examined family-centered practices in 6 early intervention preschool service providers through in-depth interviews with the providers and the families they served. The following themes of family-centered practice emerged: positiveness, thinking the best of families; responsiveness, doing what needs to be done; orientation to the whole family; friendliness, treating parents as friends; sensitivity, able to put yourself in the parent's shoes; and then a therapist having child and community skills. Another study in 2005 documented similar findings. Families acknowledged therapist behaviors related to respect, caring, communication, interaction with children, compassion, personalized care, and that providers had technical competence. So family-centered care does not mean that we need to forget about our practice knowledge and our skill, the expertise that we do bring to this family professional partnership. In several reviews in looking at the effects of family-centered care, researchers have identified the following consistent characteristics: fostering relationships, communicating and sharing information, collaborating, fostering family choice and involvement in achieving desired goals, building on strengths, and providing support. Family-centered practices that foster parent involvement, that is, those participatory practices, had a stronger association with outcomes than practices that foster the parent-professional relationship. Okay. This was surprising at first. Okay. So it's not saying that the relationship's not important. The relationship is the grounding. But we need to go beyond the relationship and support the families in being able to participate in their care. So this finding led me to focus on the understanding of engagement of families in intervention. Engagement refers to the active investment and involvement of children and parents in the intervention process. It involves a relationship among the client, family, and service provider. In the optimal situation, the family is ready, they're receptive and hopeful, they're willing, they're committed to the intervention, and they're able to participate in the intervention. They're confident. My colleagues and I, led by Jillian King, are currently studying engagement in pediatric rehabilitation. Engagement is dynamic and complex. It's influenced by client characteristics such as age, personality, and preferences, service provider characteristics such as therapist demeanor, philosophy, and approach, and organization system intervention characteristics. Engagement is a multifaceted state of affective, cognitive, and behavioral investment. It is through this investment and the provider's support of this investment that family self-determination and self-efficacy are enabled, that real-world practice and successes occur, leading to meaningful real-life outcomes. We recently published a study examining 10 cases of solution-focused intervention. And what did surprise us was that in addition to engagement, it had to be coupled with these real-world practices and successes. Only when it was coupled with that did we have the achievement of the client's goals. So we need to learn how to not only engage clients during the session, but also that they have the knowledge and skills to be and the opportunities to practice in their real life and have successes. Engagement is grounded in motivational theories such as the self-determination theory. So by attending to basic psychological needs of autonomy, that a person has control and choice, relatedness, that they're connected and supported, and competence, it is through these that we can foster motivation, engagement, and effectiveness of intervention. In order to foster this dynamic driving force, we need to recognize that motivation is an interaction among an individual's interests, their social environment, and the nature of the activity involved. The dimensions of engagement are interconnected but distinct. Affective engagement is an emotional involvement, of feeling, of being optimistic, positive attitude. There's trust in the provider and the process. They're receptive. This relates to a positive outcome expectancy. We have hope that things we're going to achieve our goals. Cognitive engagement, how a person is thinking, their beliefs. So they're committed to the goals. They believe in the relevance and effectiveness of the intervention. They're willing to invest effort. This relates to intervention suitability. Behavioral engagement, self-efficacy, that a client feels supported and able to do the intervention activities. They have the knowledge, skills, resources, and supports to implement strategies to support their goal. This relates to intervention feasibility. Research on engagement in pediatric rehabilitation is limited. Related to children's engagement, we have known for many years that children's motivation is associated with outcomes, but other aspects and indicators of engagement have not been studied. Related to parent engagement, we know that parent participation in setting and evaluating goals, parent being present and involved in the session, and parents developing and participating in home programs are associated with positive outcomes. The first two phases in our research program on engagement were qualitative. We conducted interviews and observed therapy sessions to gain an understanding of engagement from the perspective of service providers, parents, and youth. Service providers shared their thoughts of why engagement is important. They discussed that engagement gives confidence, empowers, gives control and ownership, motivates the client, enables the development of self-identity. I love this one. Creates a turning point, a shift in the client. Leads to follow-through on home programs and implementation of suggestions, and fosters client satisfaction with the therapy services. So these findings supported our framework that engagement is multifaceted, affective, cognitive, and behavioral. From parents in our study, we also heard a strong focus on the collaborative relationship with shared understanding and participation, and their comments also reflected elements of affective feeling, cognitive thinking, and behavioral doing. So the connection between the parent, patient, and the therapist is a very unique one. But it has to be. You have to trust them, and they have to love your kids like their own. It's like a collaborative effort. It's not a one-sided, this is the way it's going to be kind of thing. Don't tell me it's got to be necessary. It might very well be necessary, but it's up to your job to present the evidence to me. Okay? And then let's all kind of collaboratively come to a treatment plan. So these are parents speaking when we ask them what is engagement and what engagement is to me, and how do they feel involved in their therapy. Like, it just makes you feel valued. Okay? So that's that feeling. And it's not somebody dictating what's best for your child. It's them partnering with you and saying, okay, what can we do to help out? And if they're suggesting something, they're open to explaining the benefits, like the pros versus the cons and stuff like that. It just seems to be much more open and transparent and much more cohesive. So cohesive, that cognitive understanding. They're able to hold what this intervention is. I think we worked as a team. I think there was lots of collaboration. I would say that it's a very balanced in terms of what we're doing. I would say that the relationship is much more of a partnership than it is about someone dominating or being the teacher or whatever. I'd say it's very collaborative, back and forth, balanced relationship. So when I think about then how can we foster engagement, I think, do we invite client participation, decision-making in all phases of the therapy process? Are therapy sessions and intervention energizing and motivating? Do we instill hopefulness in meeting goals, hopefulness in the process? Do we provide coherence with respect to the intervention? And do we instill confidence in accomplishing the therapy tasks and practicing skills? In developing our observational measure of engagement, we looked at indicators of engaged interactions. These indicators of engaged interactions are aligned with family-centered care elements: a person's body language, their open posture, their strength-based language. They're focusing on abilities and solutions. They're supporting resiliency, providing encouragement. Their warmth, there's an attunement, responsiveness, caring. Active listening, checking for understanding, validating, effective use of silence. And there's collaboration. There's a reciprocity between the family and the provider. All are contributing to discussions and activities. So in talking about strategies to foster partnership and engagement, I have found that families are caught by surprise when I ask them, "How would you like me to serve you?" But this simple invitation sets the stage for a partnership. It is important for us to understand what families want for themselves and their children, and what they need from us to achieve those desires. It is very natural for me to see a family as a family. Yes, they are a family with a child with a disability, but I have found it important to get to know them as a family, their typical family experiences, what their days are like, what their interests are, how they define who they are, what their values and beliefs are, what their roles are within the family, and their perspectives on the child. What gives this family meaning? So it is important to listen to the family story and really get to know the family. Research has also consistently shown that families value the therapist as a person, so I also believe it's important to share parts of who you are with the family. Most providers believe that the profession is a calling and view themselves as advocates for children and family, but we are challenged to demonstrate commitment to each family we serve, particularly when caseloads are high. But in small ways, such as asking a family, "The following things I've heard you share with me today, which is most important to you?" And then being responsive to following up on that one thing. So this respects our heavy caseload, but also our responsiveness to the family. This approach fosters family relatedness and trust. Involving families and children in identifying, addressing, monitoring, documenting, and evaluating their outcomes in authentic ways may foster their self-efficacy. I believe it is important to gather information about what the child and family need to and want to do, their goals and their priorities. That step is essential, establishing goals together and that they are the family's goals. What the child and family can do, a strength-based approach in order to participate as fully as possible in their environment. And then as a therapist, we guide and explore with the family what may be facilitating or limiting their participation. And we create and implement a care plan together based on this information. A major theme in our qualitative data analysis on the facilitators to engagement is therapists' awareness of the family context, strengths, preferences, needs, and then their responsiveness to that. It is important to seek, value, and be responsive to family input, but also provide informed options and information to ensure understanding and assist families in accessing resources and support. We need to respect their decisions and approach that is best aligned with their culture and lifestyle. I love this quote from a parent. "The input that I did offer was well received and seemed to be, welcomed and appreciated, and even continued upon." I love that part, continued upon, because I think sometimes that's what's missing. I think we are really good in asking families about themselves and what's important to them. But then I often find that the intervention plan has no connection with that. So it is through these strategies that we can foster family autonomy. Another strong theme from our work is the need to individualized intervention. And this has been the hardest thing because we hear that there's systems barriers to doing this. Therapists need to be flexible and able to make adjustments so that interventions fit with the family's routines and are compatible with their values, interests, and situations. Therapists coach families to acquire the skills that they have identified they need in order to be able to care for their children. Therapists support home and community life. They invite family members and other individuals important to the family to be involved in therapy sessions. If they're not able to provide therapy in the family's natural environments, they use technology to connect with family members and the family's context, such as through sharing videos. They involve families in problem solving, creating solutions, they ask, and doing the intervention strategies. They ask families, would you like to do this together? Do you want to try this? What resources do you need to be able to do this at home? And then they follow up. Did the strategy we talked about last week work? Let's talk about what could make it more doable. Or is there something else that we need to try? These strategies enhance family competence. And we do this by having fun, being creative, and bringing a sense of friendship and at times humor to our sessions. I want to bring us back to why we are developing a partnership and engaging families. The goals of family-centered care are to support the family, promote quality of life of the family, and support the child, enhance the growth and development of the child through a partnership with the family. We need to balance this support to the child and the family. Another theme from our research was parents' strong value of our connection with their child. The strongest words from one mother were as follows: I want my son to have a relationship with the therapist and not the therapist at me. This was a little surprising to us. Not that we knew that they valued the child and therapist having a relationship, but how strong they valued that. So that did make us take a little step back and say, okay, we need to be responsive to this. So this is from a mother, but another father shared that maybe a therapist actually views his engagement as pretty passive. He sits in the back of the room and he kind of sits there and doesn't really participate in the session. But he says, but I'm taking it all in. He says, I better take it all in because when I get home, my wife's going to drill me. But he says that he really sincerely thinks about what the therapist is doing. He will ask questions if he doesn't understand. But he said, I need for my 4-year, now his daughter was 4 years old. So this was not an older youth. This was a 4-year-old daughter. He says, I need for my daughter to learn how to negotiate the world. I don't go to school with her, preschool with her, and I can't be with her all the time. She needs to interact and develop relationships with other people. So that was really powerful. I just continue to be humbled by what we learn from the voices of families. So when we support the family and promote quality of life, we want to make sure that the primary needs are met and each member has the opportunity to pursue the goals that are important to their happiness and fulfillment. We do this through focusing on family interactions and relationships, daily family life, parenting, financial well-being, emotional well-being, health, physical environment, productivity, social well-being, and advocacy. And not one service is going to be able to do this all, and that's why we need to have a collaborative team approach in family-centered care. One area of my research in supporting family quality of life is focusing on parent-child interactions. I believe it's the context for intervention. It's a natural learning opportunity. It's what happens in that family's daily life in a variety of contexts. It respects the parent's primary role in nurturing and loving their children and the need for enjoying our daily life and our interactions as a family. It promotes reciprocity between the parent and child. And as a therapist, I can use my expertise to guide the parent's sensitivity and responsiveness to the child's interests, cues, and needs. My focus on supporting the child has been on self-determination and supporting their roles as a family member and peer. Self-determination is the process of taking responsibility and providing direction for one's life goals. It is related to children's adaptive behavior, their flexibility, and ability to respond to environmental demands and interact with others in a variety of situations. In our research on children with cerebral palsy, we have found adaptive behavior to be a determinant of children's gross motor function, their self-care, performance, participation in family and community life, and playfulness. This is the one factor that was a determinant of all of those outcomes. In our Move and Play research study, we examined a multidimensional model of child, family, and service characteristics on these various child outcomes. Both children's adaptive behavior and family ecology, which was the family's relationships, their interest, and how they organize themselves as a family, were associated with children's participation in family and community recreational activities. These findings have meaningful implications for therapy. The importance to address and enhance children's adaptive behavior and family attributes to optimize children's participation. Strategies to foster partnership and engagement and providing family-centered care are not easy to implement. Providers need support to translate evidence to practice. The organizational culture is key to enable family-centered practice. It requires leadership, collective values and practices, that team collaboration, resources, systems and procedures, and family participation in intra- and interorganizational strategic planning and steering committees. Because of organizational barriers, parents may not be told of service options, they may receive a decrease in services, and there is definitely limited coordination and collaboration and continuity of care. It is important for us as individual service providers to seek out leaders and peers with similar family-centered philosophies to collectively champion this approach, and to advocate for removal of restrictive policies and support service provider flexibility based on family needs to be able to provide an individualized approach. As we end, I want to briefly mention the importance of advocating for family-centered care in education and research. The interprofessional competency domains include patient and family-centered care. We need to provide students with the foundation knowledge and skills so they can be family-centered practitioners. It starts with faculty valuing and modeling family-centered care. In our curriculum, it's essential that students spend time with families and that families provide input and are involved in delivering aspects of the curriculum. Our standardized patient lab experience should include family context, and it is important that family-centered care perspectives is embedded across the curriculum and not just in pediatrics. In our research, we have tried to move from token involvement of family consultants on our Move and Play study to more meaningful collaborative involvement of family team members to optimize research processes in our on-track study that we've done. Family-centered care in research has received recent attention. Rosenbaum advocates to incorporate family expertise in all stages of research, and funders also advocate and actually require in many situations involvement of service users in research and grant applications. In the United Kingdom, the Involve initiative noted, people who are affected by research have a right to have a say in what and how publicly funded research is undertaken. So we tried to move from consultation to collaboration. The highest level of consumer involvement is user control. We recently published a paper, our research team, that reviews our experiences and lessons learned in involving families in research as research team members. And we really believe the importance of shared values to develop an authentic research partnership. Lastly, these are some tools for you to explore on your own. They're checklists that enable us to not only reflect on our own behaviors, but can be used as you are mentoring others, as you're mentoring novice therapists, as you're mentoring students, as well as you're looking at your organization to say, is our organization family-centered? Because I believe it's only through this reflection and dedication, it's even to start with making small changes, that we can actually implement into practice the reality of family-centered care. So some concluding thoughts. Family-centered care is a collaborative partnership among the child, family, and professionals as we strive, not perfect, we strive, to support their priorities and choices. It acknowledges their ability to be active participants in the management of their care. Each one of us brings part of ourselves into the relationship and intervention process. Relationships are the foundation. Enabling families is a way to support their participation in the process and foster their relatedness, autonomy, and competence. Family-centered care is effective care, but it is challenging. It takes time. It requires the integration of the science of therapy with the art of caring. I believe it's well worth the effort. As I started with a parent quote, I would like to end with the voices of families. This video was created specific to our on-track research study related to monitoring health and participation of children with cerebral palsy, but I think it has a powerful message that is universal.
For children with cerebral palsy and their families, every day brings new abilities, capabilities, and possibilities. Working together in a circle of care, children, families, and healthcare professionals create new opportunities not only to support the healthy development of children, but to support each other as well.
So Alexander, well, he's a wonderful young man. He's inquisitive, he's friendly. I think the thing that I often think of as one of his qualities is kind of fearless.
Noel's a very lively child, lots of smiles, lots of energy, and very outgoing. You know, really have to focus on the abilities, and there's so many abilities and so much of that in her.
Mari Kendall Gilbert, she's a very fun child, usually very happy and determined. Sometimes it just comes when it comes, and I think that faith allows me to rest in that place, that whatever is to be will be.
Regular checkups are a way to strengthen the circle of care. A checkup recognizes that not all families are alike, and each child has unique abilities. It provides a space to engage and address a family's questions and priorities. It allows for assessments and results, like the developmental curves, to be shared in different ways, customized to meet the priorities of each family, and to inform decisions about rehabilitation services and community supports.
It's really about knowing the person. I think knowing what else is going on in their life, because that helps you understand how, although you might have therapy goals for that individual, you really want to embrace all the other activities or challenges that not only the individual but their family might be facing. You need to remember that even though the child, it's a therapist and a clinician providing services, they also need to connect with the child on a personal level.
I have a 10-year education in the knowledge of what has worked for my child and what does work and how she's best served. So it becomes a give and take, both them listening to us and us listening to them with their experience.
The key that we have learned on our journey is we're really the sort of the glue or the epicenter that brings all of the different providers together, helping them see that Noelle is more than just a child that happens to be diagnosed with cerebral palsy and hydrocephalus. She's got all of these other facets, and so we really try to bring all of that together and really work as a team to enable the best outcome for her.
For sharing information about the child, curves and graphs that describe development of children with cerebral palsy are being created in the On-Track study. During a checkup, a child's progress at their particular functional level can be visualized. For more detail, percentile graphs describe a child's development in a manner similar to growth curves for height and weight. A less detailed way of sharing information is similar to a stoplight. A child's areas of strengths are indicated by green lights. Areas for conversation or of concern are represented by yellow and red lights.
Maybe let's not put them and compare them to other kids, quote unquote typical kids. Let's think about what their potential is and not limit what their potential is.
I think all families are busy in different ways, and we all divide our time in different ways, and I don't think a disability defines a family.
The advocacy that we can do with others, with other families, with therapists, with doctors who are involved with her, is to make sure that they understand, do all the things that she needs to, what are the little micro steps that are in preparation to get her to that next level. Because if you don't believe she can, you're not going to do the things to get her there. And she won't get there unless you do.
Competent, caring, compassionate, creative, committed. Families have told us that these characteristics define healthy relationships within the circle of care. Checkups and check-ins allow us to celebrate all of them. When we check in, we begin to understand what is important to families. We learn to tailor information from assessments and share results in relevant ways. Checkups explore new ideas and adapt to each family's changing circumstances. Checkups inspire hope within the circle of care.
I never think about Alexander's disability when I think of him. You know, I know him as the person he is, and I guess that's what I would hope for everyone.
And I think all of our kids learn to be more empathetic because they see how hard she works, and they see other people in the community, and they have that natural instinct to say, what can we do to help?
Why we're here today and the story that we're trying to build is what's going to happen next.